Right, we're going to get a little bit faster and a bit through a few more trials now, if we can just bring it up. So what I'm going to try and do in this section is, I've got the emergency medicine section, but actually it blurs into a bit of ICU and a bit of pre-hospital as well. But what I'm trying to do for a conference like this is not tell you what you should already know, because you should already know it, but to try and get us to think differently about where we're going in the future and to maybe add a little controversy. So what I really want, the outcome of my talk, is if you go away from this and think, he's talking rubbish, but I'm going to discuss it in the bar and argue about it, that's my outcome. I want you to be sort of challenged about what you're doing now and think about the world in a slightly different way. So a few things we're going to talk about. We're going to talk about the concept of physiological resuscitation and challenge what you're doing now. Well, maybe you're not, but what a lot of people are doing. Talk about cardiac arrest and ALS, bit around chest wall trauma because it's a particular interest of mine, and then a story about post-STEMI hypotension. So that's the areas we're going to cover. A few trials to get through. So trial number one is published in the Scandinavian Journal of Trauma Resuscitation. If you don't read that journal, do. They've got some cracking stuff in there. It's one of those journals that's really developed fantastically over the last 5 to 10 years. And it's about non-invasive blood pressure monitoring. Now, it's in the pre-hospital, but I think this is absolutely the same in the emergency department about whether or not we trust the non-invasive blood pressure versus what the real blood pressure is. And certainly in my experience, then some of the machines that we give and use, we've got one machine which gives you random number generator, which is really reassuring, but not very good. And we have another machine, the Schiller, which goes, I can't get a reading, I'm not going to give you anything at all, which is terrifying. So in our critically ill patients, we're still using blood pressure as a target. Lots of reasons why that's a terrible idea. It doesn't tell you what flow is, it doesn't tell you what perfusion is, but often in those early stages of resuscitation, it's all we've got. So the question is it any good? So retrospective study, there's lots of problems with retrospective studies, but it's of interest, with the Thames Valley Air Ambulance in the UK. And what they did is essentially they took those patients where they had an intra-arterial line in, and they just compared it with what their non-invasive blood pressure readings are doing. This is not rocket science, but it is of interest. And they just looked at agreement. Now, agreement is not correlation. Correlation is where if one machine says it's high, the other one will say it's high. If one machine says it's low, the other one will say it's low. Whenever you do studies like that, that's what medical students do, and you find there's a correlation, you go, yay, it's really good. That's not what we're interested in. We're interested in if the blood pressure in the non-invasive is significantly different, that it's clinically important to us, it would make a difference to what we do with our patients. So they've defined that. In this population, 57 years old, quite young because it's an air ambulance, they only get dispatched to workable cardiac arrests. Others, there's actually a mixed bag in this one, lots of trauma in there as well. 227 patients, over 2,000 readings. And their agreement, they decided that it was okay if you were within 20 millimeters of a diastolic or a systolic. I actually think that's really wide. You know, there's a massive difference for me if somebody's got a systolic pressure of 100 versus 80 or 90 versus 70. I think they would accept that as okay. Or the MAP, the mean arterial pressure, within 10. So I think they've been very kind to the non-invasive blood pressure machine. What did they find? Roughly speaking, this. So if you look at systolic, it agrees about within their parameters, 63% of the time. Diastolic, 75% of the time. That's probably not terrible. But MAP, you may as well flip a coin. It's only accurate about half the number of times. And if you're using MAP as your target for things like management of your post-head injury patient, your post-ROS patients, this is terrible. So it's not good. And the other thing you do, they do these, if you want to go away, if you want to nerd out with me in the bar later, come talk to me about Bland-Altman plots. They're so exciting in the world of statistics. But essentially this large number of dots on here tells us a couple of things. The first is the red lines there tells us the number of readings for systolic blood pressure, this one, where there was wildly different numbers. And you can see that some of those are going to be wildly different. On the left axis, on the left-hand side, you're seeing very, very different values. The other thing it shows you is because the trend goes up, it's not a flat line. It tells you that when your blood pressures are very low, the non-invasive tends to overread. And when it's very high, it tends to underread. So in other words, when it's in the middle bit, where quite frankly I don't care because it's about right, you're okay. But if it's really high or really low, you've got a problem. Same when you look at diastolic blood pressure. So what does this tell us? And the first thing to say is that non-invasive blood pressure in your acutely unwell, critically injured, critically post-ROSC patients is not an accurate reading. So if you're using that as your target to what you're doing, you're probably inaccurate in a lot of cases. Hold that thought while we look at paper number 2. So paper number 2, so that's kind of like, yeah, but whatever. Paper number 2 is in resuscitation, and this looked at the association between the intra-arterial blood pressure and whether you get ROSC in your cardiac arrest patients. So this is a group of patients who are in cardiac arrest. We've got in there, we've put a femoral line in under ultrasound guidance, and we're measuring their intra-arterial blood pressure, and then we see what happens with this group of patients, basically looking for whether there's an association between that and whether you get ROSC. Winding this back and linking into Brian, remember that the heart perfuses during diastole. It's the diastolic blood pressure which actually drives coronary artery perfusion. And there is something about cardiac arrest management about restarting the heart. So presumably perfusing the heart must be a good idea. You agree with that? Good. Bit of basic physiology. What do they do? Again, it's a retrospective study, so this observational data. Lots of problems with that. Cardiac arrest patients, this is the East Anglia Air Ambulance, EAAA, I think it was. Cardiac arrest and art lines put in. They looked at the monitored BPs and decided whether or not they got ROSC, when the ROSC occurred, and whether the patient survived. Again, it's a slightly younger population than we see in most cardiac arrest trials because these are workable arrests that the air ambulance has been deployed to. Mostly men, a lot of MIs, some bystander CPR, slightly better than some of the trials we just talked about, and about a third of them in VF. Put in a 5 French arterial line femorally, and looked at which of these was the best predictor of whether you got ROSC. Now, interestingly, and in keeping with what I would believe was the physiology, of all the factors that they looked at, diastolic blood pressure was the one that drove it. So there's a pathophysiological argument there that this makes sense, that we are trying to reperfuse the heart with this. But then the question is, what value? Now, if you remember back to Brian, he talked in that very, very early study that somewhere between 35 and 40 millimeters of mercury, way back, over 100 years ago, was the value of putting anything through those coronary arteries. The filling pressure of the heart got you a ROSC. Oh my God. What happens when you do it in reality is you end up with a marker of about 35 millimeters of mercury, whereas if you don't achieve that, you do not get a ROSC. I think this is really quite profound in terms of what are we trying to do when we manage cardiac arrest. The current process of doing it is you go round and round the ALS algorithm, and what you're trying to do is you're trying to make sure that the individual components of it are delivered. So am I doing CPR? Am I giving adrenaline? Am I getting intravascular access in some way, shape or form? But what we're not doing is we're not looking at whether or not it's making a difference. We're not measuring the physiological impact of what we're doing. When we get ROSC, we do. When we put them on the ICU, it's all about measuring the physiological impact of what we're doing, but not really during the intra-arrest state. A couple of years ago, I went to a conference in Austria, fantastic emergency medicine conference there, and listened to a guy from the US who talked about how they had radically changed pediatric intensive care resuscitation. And they had changed their philosophy on the pediatric intensive care units from we're going to go through and do the stuff that says in the algorithm to a philosophy of we've got an art line in most of these patients. We're going to do what we can to achieve the blood pressure, which will then restart the heart. And it massively improved their outcomes from pediatric cardiac arrest and PICU. Now, that's a very different population to us, but it's the same signal that we're seeing in these. So my question to you from a philosophical point of view is, when we're resuscitating people now, are you the person who's going to go in there as your team and say, my job here is to optimize the process and doing the things which I'm supposed to be doing as well as they're supposed to be done? Or am I going to physiologically assess my patient and aim for physiological targets which will help restart the heart? Also, it's about restarting the heart. A lot of CPR and stuff is about maintaining brain perfusion so we don't have those terrible neurological outputs. But actually, if we restart the heart, that'll happen anyway. Right, let's keep going. Some other studies. I'm going to flip over to something slightly different now, which is a look at chest wall trauma. One of my many jobs, I think number 8, is I work on the major trauma ward, which means every so often I get put on a ward, which is terrible. But it's essentially we look after all the major trauma patients in our hospital from like an HDU thing. So we coordinate all the other services and look after the whole of the patient for their stay. It's really interesting to see how the patients go through. And one of the biggest problems that we have is chest wall trauma. Loads of our patients in my hospital have got flail chests or multiple rib fractures or associated spinal fractures. And particularly in the elderly, they don't do well. We end up giving them loads of other drugs that potentially don't do well. They get the pneumonias. Some of them get fixed. Some of them can't be fixed. It's a real problem. And a lot of my time is spent just managing them. What we often do up on the ward is we put an erector spine plane block in, and we put a catheter in and infuse for up to 5 days. Works very well. But down in the emergency department, I can't do that a lot of the time. I'm usually waiting for an MR to tell me whether they've got a significant spinal fracture. And that may take 24, 48 hours in my trust. So you have these patients with significant spinal injury, can't really get around the back very effectively. So the alternative is to put a serratus anterior plane block in, which is just underneath the muscles on the side. It's supposed to be very good for lateral and anterior ribs. And it's great. Fantastic. So single shot is what we would do in the emergency department, or you can put a catheter in if you're feeling funky. Does it work? So there is a nice multi-center RCT, love to see, 8 emergency departments down under, and this was in a group of patients in the ED with known or suspected rib fractures. And they did the standard care, which varied between the hospitals, but I had a look at the protocols. They all seemed pretty reasonable to me. So things like PCAs, opiate analgesia, non-steroidals, paracetamol, fine. Or they did a serratus anterior plane block, single shot. And what they look for is whether it made a difference to pain in the short term, admittedly, whether or not it got below 4 on a scale of 1 on 0 to 10, or whether it came down by a factor of 2. And that was what they considered to be an effective block. I think that's okay. That's all right. It's reasonable. It'd be nice to have some longer term outcomes powered, but it's quite small, 210 patients, mostly men, because men are stupid and get injured more often. And actually what they did is very simple. They put the blocks in, randomized, open label. Of course, you can't blind for it. And they found some fairly interesting results, actually. The pain scores definitely did come down with this. And the opiate use definitely went down as well. So it's a nice, simple technique, really easy to do. They did look at other things. So pneumonia, length of stay, mortality, didn't really see a difference. But the trial's not really big enough to show that, to be honest. But I always like a trial which tells me I'm stupid. And this is a trial that told me something I'm stupid. Because I know that the serratus anterior plane block, I'm putting it in here. So it's going to affect the nerves here. So I can only really numb the rib fractures laterally and at the front. It's not going to work for posterior rib fractures, is it? Until you look at the subgroups and you find out that the one group who did the best are the ones who should not have had any effect, the posterior group. Why is that? Now, it's either because they're recumbent, so maybe you're shoving it in here and it just actually tracks backwards, and actually under gravity it goes. That's one thing. And the other thing might be that actually we've used lignocaine infusions in chronic pain for like 30 years. You know, they've got pain in their back and you give them intravenous lignocaine, they get better. So maybe we're not actually doing a local block, we're just giving them lots of lignocaine or bupivacaine as it is. So who knows? I don't know. But there's definitely effect. So when you're in your ED and somebody says, no point in doing a serratus anterior because these are posterior rib fractures, here is the slide, get on and do it. Okay, so chest wall block, I want you to think about this as the fascia iliaca block of the chest. Now, if you come in with a fractured neck of femur, you would not dream of sending that patient with severe pain who's going to need loads of opiates to the ward without putting a fascia iliaca block in. So why would you do it for a chest where it's basically exactly the same thing? It's just as easy to do. And I'm going to predict that in 5 or 6 years' time, this will be a standard of care for chest wall trauma. Quick story, went to a cardiac arrest not so long ago. It was a young man under the age of 40, married, 2 kids, relevant, collapse, bystander CPR, VF, shocked, 3 shocks, came back, had some adrenaline, did well, got an output. It's a STEMI on the ECG. Actually, I'm kind of thinking, cool. This is somebody who we're going to do really awesome work with. I'm going to meet this person in a month's time. They're going to go home. We're going to see them back at the base. We're going to shake their hand. We'll have a picture and everything will be great. You know, those are the patients who you think that we're going to have a great output with this patient. So we get them into hospital. They've got a STEMI, big anterior STEMI. They get to PCI. They got terrible disease, unfortunately, for whatever reason, and they don't do well. And effectively, they end up in cardiogenic shock. They don't do well post PCI, and eventually they get onto the ICU. They get flogged with a various number of vasopressors. We have a different system to ECMO in the UK. Have you come across it? It's called ECNO. So we have 4 beds in the northwest. There are some ECMO centres. It's very difficult to get into them. So this person was in the wrong place. They were in the wrong hospital. They didn't get ECMO. It wasn't an option. And he died. And it's really sad. And you think, no, there's potentially a better option there. Now, has been the Danger Shock trial, which is 14 centre multi-centre RCT published in the New England Journal of Medicine called the Danger Shock Trial. And what they did is they didn't do ECMO for this group of patients. They took the patients with cardiogenic shock post-MI and put an impeller in, which is like a little propeller thing. Oh, it's an impeller, actually. And it's a device which supports the heart. So it supports the cardiac output. And they looked at mortality at 180 days compared to standard care. You have to be pretty sick to get in this trial. So you've had your MI, you've got a STEMI, you've got an average age of 68, you've got to have all of these things. You've got to have low blood pressure, you're already on inotropes, you've got a high lactate, your left ventricular ejection fraction is rubbish. What did they find? Well, actually, it's really interesting. 180 days, huge difference in output. There's clearly a very sick group of patients. Mortality rates are really high, but you've got a number needed to treat there of 8 with an impeller. Now, an impeller is something which you can put in a PCI lab. It doesn't need to go to Sydney and Brian's ECMO unit. It can be put into anywhere where you're doing PCI. So this is really interesting. The graph here, I'm not sure if you can see it, but the bottom line is the survival with impeller. You get better survival early on, but it's maintained. If you don't get the impeller, you have worse survival early on, and you continue to die up to 6 months, which suggests that these people have developed heart failure. And you guys are skiing. I don't ski, but had a trip to an orthopedic surgeon once. It was bad. But if you strain your calf muscle here, and you've injured your muscle in your leg, what we don't do is we don't kick you around Zermatt, making you keep going in the hope that it's going to get better. But with our hearts, if you don't have access to ECMO and things, you get a myocardial infarction. What we do is we kick it harder and harder and harder and harder with inotropes and expect it to get better. It doesn't work. Maybe it needs a bit of support. And so this trial is quite interesting, that it does reinforce this idea that flogging a failing heart is not going to make it any better. And other techniques like intra-aortic balloon pumping and stuff, there's been trials of that in the past as well. And that also shows that it doesn't make any difference. But this is potentially a technology which could go on. Right. One, maybe 1.5 trials. The last one is going back to cardiac arrest again, because I think cardiac arrest is fascinating that we think we have it sorted and we don't. Do you remember the DOSE VF trial? Great trial in cardiac arrest, randomized controlled trial of standard care, defibrillation or vector change, moving from anterolateral to AP, or dual sequence emergency defibrillation with 2 machines going bang, 1 second later bang, like in Frankenstein's monster, and you make the patient go back to life. Big flash. Pretty cool. And it showed that both of them improved ROSC rates, but dual sequence definitely improved your mortality. Now, I spoke to Chesney, who did this trial, Chesney Speaks, who, if you ever want to invite someone to conference, invite him and his wife. They are absolutely fantastic people. Strong recommend. And what they did is they went back and had a look at the data and said, well, actually, we're supposed to be 1 second apart, basically because the defibrillator manufacturers wouldn't allow them to do it at the same time because they thought they might damage the machines. But it was manual. It was like 1 second, 1 second. Was it? It was never actually 1 second, or maybe a couple. It varied. So they went back into the data and said, well, actually, does it make a difference if you're far apart or close together? It's a good question, because I always felt more electricity. It just looks cooler when you do it at the same time anyway. So did they do that? So they looked at this secondary analysis. Always got to be careful with secondary analysis. It's hypothesis generating. Timing of the shocks, looking at ROSC and mortality. And what they found in the patients where they could get this data out, 106 patients, 300 shocks, what they found is this. The quicker you did it, the more chance you got of getting ROSC in these patients. And that makes sense to me. In that what you're trying to do with dual sequence is defibrillate the whole damn heart. So do it close together. You're much less likely to end up with a recurrence of your VF. You get them out of VF. So we need our manufacturers, at the back down there, to go away and make us machines which can possibly do this closer and closer together. However, secondary analysis, got to be careful of that, hypothesis generating, etc., etc., etc. But it does look as if the quicker shocks means more ROSC. I think that's interesting. And then very quickly, another secondary one, recurrent versus refractory. Well, the other thing that they've done this year is another nice paper, which looks at whether or not patients, and this is something I've said for years, is that there's a big difference when I'm managing defibrillation about the patient who I defibrillate, who just, the defibrillation doesn't work. They just carry on in VF. The defibrillation did not work. Versus the patient who you defibrillate them, you see some complexes, and then they go back into VF or VT. So one of them, the first group, in my opinion, needs more electricity. They need to be defibrillated. And the second group needs something to stop them going back in, which may be drugs. Now, I don't have the evidence for that, but in the secondary analysis of the same trial, they've shown that there's a big difference. You're much more likely to survive if you get properly defibrillated, which means more juice. So another one. Again, isn't it fascinating? Cardiac arrest, we know everything. We know how to manage it. We all know our ALS algorithms, but everything can be questioned. Everything can be refined, and we've got a long way to go. Right, thank you very much for your time. And we're going to hand over to, if our patient survives, Rod.